Hi, thanks for the invitation, and it's gonna be a very informal lecture, just try to be very practical about what you guys as adult ID physicians might want to know about congenital infections, and feel free to ask any questions that you have during the lecture. So, my objectives tonight are to review the history of torch, go over the types of congenital infections that you might see in neonates, what are the most common clinical findings of congenital infections, what is the current diagnostic approach, go over some cases and go over some of the available treatments that we have so for some of those congenital infections. So you probably learned the TORCH acronym during medical school. It was coined in 1974, so generations of medical students have had these ingrained in their brains. And the problem with it's a good acronym to remember all the congenital infections. I mean, it's toxoplasmosis, rubella, cytomegalovirus, and herpes viruses, and the always others like HIV, parvovirus, lymphocytic meningitic virus. The problem is when you just go and are lazy and decide or do like the neonatal physicians that just order torch titers on a baby because they're completely useless by now. And it's just something that the diagnostic companies have put out there where a lot of tests get done, a lot of them are completely useless, and they just charge a lot of money because it's a lot of testing. A lot of them you don't even need to do. So hopefully after today, if you have to see a baby with a congenital infection, you'll make a good approach to how to make the diagnosis. The problem with a lot of these infections are that they are asymptomatic at birth, especially because the majority are going to be caused by CMV, so the majority of those neonates are going to be asymptomatic and they're just going to have hearing loss later in life. Again, if you use the torch titers, you may miss a diagnosis because it's a poor screening tool. Most of the titers are just reflection of maternal IgG, and there's much better molecular biology testing or other serologies that you can do in the baby that are much better tests in general. So the time periods where there can be transmission of pathogens in neonates are basically divided in three. There's prenatal or in utero, and that's where you might also get involved, especially if you get referred like a pregnant woman that's infected with, like, probably the most likely thing you're gonna get is the syphilis, and especially nowadays when we have a big epidemic of syphilis going around in the United States and also in Hillsborough County, and that's where we really need your help to make sure that the moms get appropriately treated, that they get their 3 doses of penicillin every week, so that then we don't have to deal with the baby and with the results and what to do and if we need to keep them or not. So that's would be very important. The other time period is the perinatal period or the delivery period, especially when they go through the birth canal and they're exposed to the maternal blood. A lot of transmission can occur there, also from the flora, from the birth canal, from both the maternal or the GI and genitourinary tracts. And then there can also be postnatal transmission, especially from caregivers and also from breast milk. And those are some of the viruses that can be transmitted by breastfeeding. So HIV and other retrovirus, HTLV1, CMV and rubella. And that's a board question, like a lot in pediatrics, is the ones where the moms are told not to breastfeed, and it's the retroviruses, HIV and HTLV1. That's the recommendation here in the US. In other places where there's no good sanitation, they still do breastfeeding even on HIV infected mothers. So the types of in-utero infection, we can divide them by pathogens, and the most common one are viruses, especially as I mentioned before. The most common congenital infection in the US is cytomegalovirus or CMV, but varicella, rubella, parvovirus, B19, lymphocytic meningitis virus, and HIV can also be transmitted in utero. In terms of bacteria, it's Treponema pallidum, the cause of syphilis. In terms of protozoan, Toxoplasma gondii is the most common one here in the U.S. It's not very common like in other European countries, like in Italy and France, where like steak tartare is very popular and they eat raw meat. They have a huge problem with toxoplasmosis. In the U.S., it's very uncommon, but there have been some cases described of Chagas disease or Trypanosoma cruzi of congenital infections. But now that we have an increasing migrant population, we have to take that into account because that's a very common cause of congenital infection in like Central and South America. And then there's a bunch of other infections that can happen after birth, like at the time of delivery, like especially herpes simplex virus, CMV can also happen, enteroviruses, human papillomavirus, and laryngeal papillomatosis is a big problem in children, varicella zoster virus, some bloodborne pathogens, especially hepatitis C, since most mothers here in the U.S. are already vaccinated against hepatitis B, but hepatitis B still is a big problem in the rest of the world. In terms of bacteria, Group B streptococcus is the major problem and most common cause of bacterial infections in the neonate, of sepsis, meningitis, pneumonia. Moms get screened during the pregnancy and they get prophylactic antibiotics at labor if they're colonized with Group B strep, and that has decreased the incidence of early onset Group B streptococcal infections, but not late onset infections. Some other common ones are like staph species, like Listeria monocytogenes is for some reason one that they love to ask and test in the boards, but it's basically maybe one case a year or every 2 years. It's very rare. We do see a few cases of Neisseria, gonorrhea, and chlamydia trachomatis, especially ocular infections that need to be treated appropriately, and then some candida infections. So this is a slide showing the epidemiology of congenital infections in the U.S. And it's per 100,000 live births, and as you can see, CMV is by far the most common congenital infection. There's like 1,000 cases per 100,000 live births, but only 10% of those are going to be symptomatic at birth, so it's going to be around 100 cases that are going to show the symptoms. The rest are going to be completely asymptomatic, and the problem is that another 10-15% of those are going to go on and develop hearing loss from the CMV infection. So those are the ones that we're trying to develop some techniques so that we can detect. And now that there's better treatment, a lot of people are calling for neonatal screening for CMV, so that's something that might come up down the line. The other most common ones are syphilis, toxoplasmosis, and HIV. Congenital rubella in the U.S. is extremely rare, but it's very common in other parts of the world where rubella immunization is not part of the routine immunization schedule. And then herpes simplex and varicella are also very uncommon. So just a very quick review of the neonatal immune system. Prior to 15 weeks of gestation, there's very poor maternal antibody crossing of the placenta. The majority of the maternal antibodies cross the placenta in the last trimester of pregnancy. There's very poor fetal antibody production at less than 20 weeks of gestation, and after 30 weeks, the development of organism-specific antibodies develops. There's also decreased chemotaxis and intracellular killing, and also at birth, the surface barriers are not as good as the older children. They have a very mature skin, and they also have decreased secretory IgA on their mucosal surfaces. So getting a good history is always very important, especially for congenital infections, and that can be very helpful, like a history of travel where the mom has been, what's the country of origin, that can give you an idea of what immunizations she might or might not have received. Again, as I mentioned, Chagas problem, what's their occupation. There's certain occupations, like if they're like nurses or they work in a daycare center, they have a much higher risk of being exposed to like CMV or parvovirus B19 and have a higher chance of having one of those infections. Animal exposure, the big one again is cats, and that's why pregnant women are told not to manipulate cats' feces and urine, and don't change the cat boxes. But I mean, so it's important to know then the diet. If they eat like raw meat or like fresh cheese, puts you at risk for like Listeria monocytogenes. Then the history of herpes simplex virus. But remember that only 25% of the babies that have a congenital herpes simplex virus infection, the mom has a history. The majority of moms that end up having a baby with the baby has herpes simplex in the newborn period. 75% of the moms didn't even know about it. They had a completely asymptomatic infection, and they were just shedding the virus without knowing it. A lot of times it's useful to ask about illnesses during the pregnancy. Sometimes they might recall, oh yeah, I had like a flu-like illness or some other problem during the pregnancy. If there were any other complications with the pregnancy, especially labor delivery, and if there was use of fetal scalp monitor or skin breakdown. Like that's a classic question. Usually if there's a fetal scalp monitor and they tell you baby's getting vesicular lesions, it's like a herpes simplex infection. In the US, moms are, if they go for prenatal care, they're screened for syphilis, hepatitis B and C, GBS, rubella, HIV, gonorrhea, and chlamydia. So hopefully you'll have all those results available to you. Again, that's if they have been to prenatal care. A lot of times we get moms who have not accessed prenatal care and they haven't had this testing done, or they have refused some of it, or sometimes they've tested for syphilis and they got like one dose of penicillin, and then who knows what happened afterwards. There's no records of any other visits. So but it's always useful to have that information, especially if the baby tests positive for one of these agents. Physical exam, again, is very important, and in general getting the weight and the length, and knowing if the baby is of a good size, he's adequate for gestational age or not. A lot of times with congenital infections, you're going to have what's called intrauterine growth retardation, so the babies are going to be small. Head circumference is also important to know. Most of the babies that have microcephaly, if it's from a congenital infection and not from like a genetic syndrome, it's going to be from CMV or sometimes rubella. Toxoplasmosis can sometimes cause the opposite, can cause like hydrocephalus, so they're going to have an enlarged head circumference. A lot of these infectious agents like CMV or herpes simplex or rubella or toxoplasma also have tropicity for the eye, so getting a good eye exam is extremely important to make a good diagnosis, and also know at baseline how they presented. The skin exam is also very important. If you see like jaundice initially since birth, that's completely abnormal. If you see any type of rash or petechiae, that's also important to notice. And some of the most common findings are going to be the petechiae at birth. So again, these are some of the eye findings that you can see in the infant. There can be like chorioretinitis or keratoconjunctivitis with herpes, glaucoma, and pigment retinopathy and cataracts can be seen with rubella, and herpes simplex varicella and toxoplasmosis can also cause cataracts. Some of the other agents can give you microphthalmia, and iritis, and there can also be hearing problems with, especially with infants that have CMV infections. So they need serial hearing examinations. The recommendation is to do testing every 3 months every 3 months for the first year, then every 6 months until they're age 3. Once they're past that, supposedly there's not much risk anymore. Rubella can also be associated with deafness. A cardiac exam is also very important. Looking for hepatosplenomegaly is also important, and doing a good neurological exam, since, as I said, some of these agents can also go into the brain and cause some neurological damage. In terms of the viral infections, some of them CMV is the most common one, and is present in between 0.3 to 2% of all live births, depending on the case series that you looked at. Many can, as I said, go unrecognized or asymptomatic at birth. Some of these infections can also have very similar presentations, so it's just very important to do a very good workup. And lymphocytic choriomeningitis virus can mimic CMV. A lot of times you think it's a classic CMV case and all the testing comes back negative. In that case, it might be worse testing for the LCMV. Some of the clinical findings in viral infections, and these are like the classic findings with CMV, you see like microcephaly, petechiae, what's called like a blueberry muffin baby, because they're having hematopoiesis outside of the bone marrow, and they can also have cholestatic jaundice. With rubella, what's classic, it's presence of cataracts, heart disease, especially pulmonic stenosis, and deafness. With varicella zoster virus, they can have scarring of the skin, limb hypoplasia, and ocular abnormalities, especially if it happened very early during the pregnancy. And with herpes simplex, you can have ocular disease and skin scars. So these are some of the common clinical manifestations of some of the most common congenital infections. So as you can see, prematurity is common to like the most common ones like rubella, CMV, toxoplasma, and syphilis. Intrauterine growth retardation is also common in most of them. Microcephaly is most common with cytomegalovirus, but you can see it with rubella. And then with toxoplasmosis, although sometimes you can see microcephaly, the most common finding is usually hydrocephalus. Both CMV and toxoplasmosis can give you intracranial calcifications, but usually CMV are periventricular calcifications, and with toxoplasmosis are more peripheral calcifications in the brain. You tend to see hepatosplenomegaly with most of them. With rubella and syphilis, you can see bone abnormalities. They can also, all of them can cause anemia, like a mild anemia. And with CMV, you can also see very low platelets. In terms of diagnosis, you can start with some of the routine labs, like a CBC with differential and liver function tests. Some of these, especially like herpes and CMV, are gonna give you also like hepatitis. And then there's more specific testing, especially antibody, antigen, culture, which is not used that much anymore, but pathology, especially of the placenta, and some biopsies. And nowadays, especially PCR is really helpful in terms of making the diagnosis. A good eye and hearing exam are also very important as part of the workup of a congenital infection. And in terms of diagnostic imaging, head ultrasounds and CT scan and MRI can also be very helpful. Long bone X-rays can be helpful, especially with babies that have syphilis, although it's very unusual to see any findings. As I said before, in terms of antibody testing, IgG in the infant may only reflect maternal antibody, but maternal antibody, especially the IgM, getting acute and convalescent titers with a good history might be very helpful in terms of making a diagnosis. In terms of the baby, for herpes simplex virus, serology is not very useful. It's usually a reflection of maternal IgG. There's cross reactivity between herpes simplex virus 1 and 2, and there's really not much clinical difference. Culture is very good, and you, since it's such a rapidly growing virus, You can get results in 48 hours, and PCR is even better, and you can get the results quite fast. Um, you can do PCR like surface lesions if you see any vesicular lesions, and then like what the Red Book or the American DAP Committee on Infectious Diseases recommends is like babies who are born in moms that have a history of HSV, or where you have a clinical suspicion, is doing surface cultures like you can do culture or PCR of the mucosa of the eye, oral mucosa, the umbilical area, and rectal area. With CMB, the serology is again not useful. It's usually a reflection of maternal IgG. You can have a false positive IgM, but you can do PCR of the blood and the urine, and that can be very helpful. For LCMB, you can do a maternal IgG, and if that's positive, then you can check the maternal IgM and then the infant IgM. For parvovirus B19, if the mom is IgG negative, then you can rule out infection in the infant. But if you suspect infection in the infant, the best test is to do a PCR, and then if you get like a positive IgM for rubella in an infant, then you can do a culture of the nasopharynx and the urine. If a mom is non-immune in the first trimester, when they access prenatal care and they test as being non-immune, and that sometimes happens with some moms who have come to the U.S. from other countries, then you should repeat the titer late in the pregnancy to see if there's been any seroconversion during the pregnancy, and then you also should make sure the mom gets immunized pretty soon after the delivery. With HIV, the antibody, as you know, it's just a reflection of maternal antibody up to 15 to 18 months of age. So HIV DNA PCR is the gold standard, and we usually test at birth to see if there's any neuroinfection, and then at 2 and 6 weeks of age, and at 4 months of age. For hepatitis C, again, it's IgG is a maternal antibody. So what do you need to do? The hepatitis C RNA PCR. For hepatitis B, you can do a surface antigen, but the most important thing is to check the maternal status. If the mom is a chronic carrier of hepatitis B, then there's hepatitis B immune globulin and the hepatitis B vaccine, and they should be giving at birth at 2 different sites, and that basically has eliminated congenital hepatitis B infections in the U.S. In terms of syphilis, you need to determine the mother's serologic status, and they get checked during the pregnancy. And if they are positive, ideally they should have gotten treatment, and you should repeat the titers at birth and make sure there has been a good response, and then check the tests on the baby. If they're positive, then you also need to get a spinal tap and do a BDRL of the CSF with cell count and chemistry, because that's gonna modify the type of treatment that you're gonna give to the baby. In terms of toxoplasmosis, the one that's usually done in the commercial labs is not very good. So whenever we have a suspicion of toxoplasmosis in a baby, we send a special antibody panel to Dr. Remington's lab in Palo Alto in California. He's like the expert on congenital toxoplasmosis, and his lab does a very good job of determining if a baby is infected or not, and they also provide very good feedback. So again, PCR has a high sensitivity and specificity. There's fewer false positives. The diagnosis can be made very quickly, and it's very advantageous for viruses that are difficult to culture, such as hepatitis viruses, parvovirus B19, HIV, rubella, and Epstein-Barr virus. As you might know, it's available for many pathogens, and now the lab here at Tampa General has moved completely to just PCR testing. They are not doing any viral cultures anymore, but you might still practice in areas where they're still doing, like at all children, they're still doing, they still have a virology lab that does viral cultures, so you might still get some of those results, especially for CMB. If you do have a culture of the urine in the first 3 weeks of life, you get the results usually very quickly. That virus grows very fast. So, like for CMV, you can isolate from urine, saliva, throat, and usually if it's in the first 21 days of life, you know it's a congenital infection. Some labs still do what's a shell vial assay. That's like a quick way to do the diagnosis. For herpes simplex virus, again, culture can be done from maternal lesions if they are present, and then from the different surfaces where the virus might be present, and you should do it at least after 20 hours after birth, so you know it's a true infection and not just a transient colonization. In terms of the pathology, you can do special stains, especially from a liver biopsy. And one of the important things, and what I try to remind to the pediatric residents or the neonatal fellows, is that sometimes if there's CMV abnormalities on the babies, to request that the placenta be examined, because the pathologist can do a lot of special testing and look for a lot of things in the placenta, including findings that are very specific, like inclusions within cells that are seen with CMV. With rubella, you can see necrotizing angiopathy with inflammatory foci, and with parvovirus, you can see nucleated RBCs with intranuclear inclusions. In terms of diagnostic imaging, fetal ultrasound can sometimes be very helpful, but you really need a very good ultrasonography because the findings can be very subtle or negative early in the pregnancy. But sometimes if they see like echoic foci with that can be compatible with intracranial calcification, then you might want to get a better type of ultrasound. The head and fetal size are again important to follow to see if there's symmetric or asymmetric growth. Cardiac abnormalities, hepatosplenomegaly, any type of effusions like pericardial or pleural effusions can be associated if there's hydrops fetalis, and they also look at the amniotic fluid volume. Once the baby is born, a head ultrasound can be a very quick screening method. You can look for growth abnormalities, calcification, especially for CMV and also for enlarged ventricles. Abdominal ultrasound can again be helpful to look for hepatosplenomegaly and calcifications. Cardiac echo to look for congenital heart disease. CT scan and MRI can sometimes give a more detail than head ultrasound. Most of the babies just get a CT scan because you can get that done very quickly, and you don't need all the sedation or all the other technical problems that you have with doing an MRI in a newborn. And then X-ray, as I said, can be helpful for especially for long bone examination. This is just an example of a head CT and an MRI showing these multiple periventricular calcifications in a case of CMV infection. So I'm just gonna go over some cases very quickly, and a lot of them are cases that we've had here or all children's. First one was a baby girl who had was born at 32 weeks of gestational age, and it was like an emergency C-section for severe fetal hydrops. This was the mom's second pregnancy. She had prenatal care, and really a completely uneventful pregnancy until she showed up to one of her appointments, and when they did an ultrasound, they realized the baby was hydropic, and when they did a follow-up ultrasound a couple of days later, the baby was getting much worse, so they decided to go ahead and do an emergency C-section. When the baby was born, she had generalized edema, she had coarse breast sound, distant heart sounds, she had bloodberry muffin ecchymosis on the trunk and extremities. So this baby had a very clear case of hydrops fetalis. As you can see, there's multiple causes for hydrops fetalis. Big categories are cardiac, and then the two big categories can be immune or non-immune hydrops fetalis, and within the non-immune are all the congenital infections. The most common causes are parvovirus B19 and cytomegalovirus, but there's other agents that have sometimes been described in some case reports. In this case, what the baby had was parvovirus B19 infection, and this is a DNA virus that was discovered by accident in 1974 when they were trying to find the agent for hepatitis B. And until recently, it had been the only parvovirus that had been described as pathogenic in humans. Now there's been other parvoviruses that have been discovered. It's distributed worldwide, and it has a tropism for the erythroid cell line. It binds to the blood group P antigen, which is present in the membranes of red blood cells, and that's why it causes such a severe anemia. But that that same receptor is also found in megakaryocytes, endothelial cells, and fetal myocytes, and that's why it causes such a severe problem in fetuses, and is not as severe in older children. So infection in the healthy host with parvovirus B19 is usually symptomatic in the majority of them. In children, it causes erythema infectiosum or slab-cheeked or fifth disease. It can cause thrombocytopenia and ITP, and it causes an immunologically mediated arthropathy that is much more common, like adolescents and adults that get a parvovirus B19 infection. Usually 1 or 2 weeks later get a pretty bad reactive arthritis. During the majority of women have evidence of past infection, and that's protective, but the annual seroconversion rates during endemic and epidemic periods is between 1.5 and 13% respectively, and the risk of acute infection is increased if there's already children in the household, especially if there's very young children, and also if you're a nurse or working at like a daycare center, you also have an increased risk of infection. Incidence of infection during pregnancy is estimated between 1 to 5%, and around 1/4 to 1/3 of all those babies get transplacental transmission, and the risk of hydrocephalus is extremely small, and even an abnormal outcome is only 5 to 10%. But the fetus is a very highly vulnerable host because they must increase their red cell mass 34-fold between the 3rd and 6th months of gestation to meet the growth requirements, and the fetal red blood cell only survives. The median half-life is very short, only 45 to 70 days as compared to 120 days, which is the normal half-life for a red blood cell in children and adults. And parvovirus B19 can also cause leukopenia and thrombocytopenia, although not as severe as the anemia. The outcome of fetal infection is very good. 1/3 of the cases have a spontaneous resolution. 85% have survived with the severe anemia is treated with a fetal blood transfusion. It's not teratogenic as opposed to other viruses, and the neurodevelopmental outcome in survivors appears to be normal. So the second case was a female infant who was born full term by normal delivery to a 25-year-old mother this was again her second pregnancy with poor prenatal care. On admission, her RPR was non-reactive. She was immune to rubella, HIV negative, and also negative for hepatitis B. The Apgar scores were 9 and 9, but the baby had petechiae on the lower extremities and also hepatosplenomegaly and was transferred to the NICU. Anyone who wants to take a guess? Yeah, CMV, that would be the most likely culprit. And this is just an old slide, but unfortunately CDC, this is a slide from the year 2001, but CDC hasn't really updated one. But this is just giving you an idea of children born in the U.S. With long-term medical conditions, and that gives you an idea of the amount of congenital CMV disease that there is compared to like fetal alcohol syndrome, Down syndrome, spina bifida, or anencephaly, pediatric HIV/AIDS, or invasive Haemophilus influenza or congenital rubella syndrome. So it's a very common problem here in the U.S. We see a few cases every year, and we participate in the collaborative antiviral study groups that is working on a lot of the new agents and new testing to try to make the diagnosis of CMV. And we also have like a CMV, congenital CMV clinic to follow all these babies. What these babies have is dermal hematopoiesis, and there's invasive of the bone marrow. They start doing there's these all extramedullary hematopoiesis that occurs in the dermis, and that's what causes all these petechial ecchymotic lesions that are, when the baby is born, they're usually called like a blueberry muffin baby, and that's kind of classical with CMV. Although you can also sometimes see it with parvovirus B19. Third case was a 36-week-old male who on day of life 4 developed fever, irritability, and hepatitis. There was a paternal history of fever, myalgia, and URI symptoms like 1 week prior to the birth of the infant. This baby, actually what he ended up having was an enterovirus infection, which can be quite severe in babies, and it can lead sometimes to like a severe myocarditis that sometimes requires like a heart transplant. Sometimes like also severe hepatitis that ends up requiring liver transplant. And we'll talk a little bit about the only available treatment that's available in a compassionate base. Next case is a 30-week-old female who was born to a 17-year-old mother that had come from Peru and didn't have any prenatal care. The physical exam, she had extensive purpura and petechiae. She had heart murmur, and in one of her eyes she had an absent red reflex. And this baby actually had congenital rubella syndrome. So although the majority of women of childbearing age in the U.S. are protected against rubella, so they cannot get it because they have immunized. As I said, a lot of people that come to the U.S. from countries that receive the World Health Organization immunization program, they receive the measles vaccine, but because the MMR vaccine is so expensive, they don't get the mumps and rubella part. Although pretty soon they're talking about including it. But so a lot of those mumps are not protected against rubella. You know, rubella virus is an RNA virus of the Tachypiridae family. In terms of congenital defects, and that's similar to a lot of other congenital infections, the earlier that the infection occurs during the pregnancy, the more likely that they have infection, and also the more likely that it's like usually like a severe infection. There's 85% chance of congenital defects if the infection occurs in the first 4 weeks of pregnancy, and that gradually decreases during the pregnancy. As I mentioned before, the most common anomalies are deafness, 70 to 80% of the cases, then eye abnormalities, neurological abnormalities, and cardiac abnormalities. Next case is a baby born at 26 weeks by crash C-section due to severe fetal bradycardia. He had poor tone, hepatosplenomegaly, and hydrocephalus. The skull film showed several calcifications, and the mom, after we talked to her, she reported having like a flu-like illness in the first trimester that she really hadn't seek care for. And this baby ended up having congenital toxoplasmosis, which can be asymptomatic in the majority of the cases. But months to years after infection, if the infection is not treated, it can lead to visual impairment, learning disabilities, and mental retardation. If the babies that are symptomatic usually show a maculopapular rash, jaundice, generalized adenopathy, hepatosplenomegaly, and meningoencephalitis.
You say so treatment definitely can affect the outcome. Can treatment completely eliminate those complications, or
sometimes some of the neurological damage has already been done, but it can get worse if you don't treat it. But the most important thing is that if you make the diagnosis and you treat it, they're also established in care, and you can hook them into a lot of different programs that if not, they're not going to get all those resources. So I don't know if it's a treatment that we give or it's just a very good care that they receive that makes for a better outcome. But in general, they say that, yeah, if you treat, there's not much better outcome than if you don't. The next case was a baby with born prematurely by C-section that had hepatosplenomegaly, a CAT scan with periventricular calcifications and chorioretinitis. We thought it was a typical case of CMV, but all the CMV testing was negative, and the baby actually ended up having LCMV infection with this lymphocytic choriomeningitis virus. And I've only seen one one case. It's been described. It's an arenavirus transmitted by rodents, especially by mouse and hamsters. So sometimes get a good pet history. And a lot of times when you ask about pets, like people just respond about dogs and cats, but sometimes you need to ask directly. Do you have like a guinea pig? You have a mouse? You have a hamster? Like lizards, snakes. A lot of times people don't consider that those pets. They have them in the house, and I don't know under what category they go under, but they're not pets. So it's like, yeah, like when you get salmonella, always ask about reptiles because they will have like a turtle or a lizard or a snake or something. In the congenital infection, you get chorioretinitis, hydrocephalus, periventricular cranial calcification, and microcephaly. Again, it looks like a classical CMV infection, but when you do the testing, it turns out to be negative for that. So we think about this other agent, and we can make the diagnosis by immunofluorescent antibody test. The next one was also a premature baby born by C-section that have abnormalities of the lower limbs and several areas of scar skin. It looked like like if she had been burned. I mean, that's kind of what the scars looked like. The mother reported a URI in the first trimester with a few itchy skin sores that developed. Probably was a very, very mild case of varicella that she didn't realize, and she had fetal infection after maternal varicella infection. And with varicella embryopathy, you get limb hypoplasia, cutaneous scarring, abnormalities, and damage to the CNS. And the incidence among infants born to mother with varicella is only 1 to 2% when the infection occurs before 20 weeks of gestation. And that's different from the infection if it occurs very late during the pregnancy, which can be fatal for an infant if the mother develops varicella from 5 days before to 2 days after delivery. In those cases, the infection in the newborn is quite severe. Number one, when they get like a disseminated varicella infection with pneumonitis, and you need to intervene right away.
I've seen over the years a couple cases in second or third trimester maternal varicella treated antivirals. Those kids usually do okay.
Mm-hmm. Yeah, and then the majority, even if you don't treat, they do very well. So I mean, so you still treat them, especially since you're making the diagnosis. Whenever I get a call from an obstetrician, I always recommend treating. Especially, I mean, it's acyclovir, valacyclovir. I mean, it's very drugs that we know we've used in newborns, and they're pretty safe. I mean,
so very early and very late, you're in trouble.
Yeah.
So when you make the diagnosis for the infant, I guess you're going to get that. How long do you treat it?
Hmm?
On the baby, how long do you treat that?
With the varicella infection? Yeah, we treat for 2 weeks. And like for herpes, if they have like CNS disease, we will do 3 weeks of acyclovir. If they don't have CNS disease, we only do 2 weeks. If they have disseminated or superficial, if they have what's called SEM, skin eye, and mucosa. So in terms of treatment, there's a lot of viral infections, and there's no conclusive evidence about treatment in general. We treat, and we always hope that we're providing benefit. Sometimes there's no good evidence-based medicine to support it, but supportive care is always very important. Having a good neonatal intensive care unit. We know that for certain infections, treatment will provide benefit, like for herpes simplex and varicella. Acyclovir does make a difference, especially for herpes simplex. It's life-saving. For HIV, we know that babies, the sooner you start baby in a congenital infection, the longer they're going to live. In terms of CMV, ganciclovir has been well proven to be helpful, and now we have valganciclovir, which we can give orally, and that prevents all the hassle of having to keep the baby in the neonatal ICU with a Brobiac in place. In terms of enteroviruses, pleconarial, which was an agent that was being developed especially to, well, the company really wanted to make it is like an agent for rhinovirus that they would use for the common cold and make a lot of money. Didn't pan out, but it's still available for compassionate use. So as I said, for CMV, we have ganciclovir and valganciclovir. The most common problems with those are little bone marrow suppression, thrombocytopenia, and neutropenia. So you have to follow with a CBC every week and make sure there's no problems going on. We recently participated in a multi-center clinical trial through the Collaborative Antiviral Study Group, looking at whether valganciclovir for 6 weeks versus 6 months in infants with congenital CMV disease have better. Which one has a better outcome? We know that at least doing 6 weeks is good. It's a standard of care, but sometimes even after 6 weeks you have not completely suppressed the viremia. So this study was looking at the outcomes after the full treatment. In terms of enteroviruses, pleconarial is available from the company that bought the original company. It's available for compassionate use. It has activity against all the enteroviruses. It has been used for enteroviral sepsis, and sometimes it works, sometimes it doesn't. Usually when we use it, the cases are so severe, we use pleconarial. We also throw IVIG in there. We try to do everything available, so we don't know what's really working when the baby survives, or we avoid like a heart transplant or a liver transplant. It has to be given in G or PO because there's no IV formulation. For toxoplasmosis, the treatment is pyrimethamine and sulfadiazine for 1 year, and you need to supplement with folinic acid to prevent the anemia that would be caused by these agents if you don't do that. For syphilis, if it's proven or highly probable disease, you do aqueous crystalline penicillin GIB for 10 days, or you can do penicillin G procaine IM for 10 days. So just to finish the talk, please don't order random screening tests or aka torch titers. Use a more selective testing approach to the infant based on your history and your physical findings, and then depending on the diagnosis you can consider the available treatment. And then the most important thing for a lot of these babies is the planning for future care, because the sequela from like CMV or herpes simplex or varicella or rubella can be so severe that they're going to need a lot of special